this has been my nightmare, but I see this potentially all unfolding in the same way and starting to encompass influenza virus. Okay, I think that we are setting up our society so that we're going to start no longer will annual flu vaccines be optional, but we're going to apply the same technology to the flu. And if we can do that, because if we highlight cases of the flu like we do the SARS coronavirus 2, and we don't differentiate mild from moderate to severe, it's going to scare everybody as well. I've told everybody that. And historically, if we ever put the spotlight like we do now on the SARS coronavirus 2, on the influenza virus, it would seem scary as well. So people have to wake up. These vaccines are poor quality. They are very poor quality, such that I would define them as garbage. I literally teach my students what good high quality and low quality vaccine looks like. Look around you. These honestly are garbage vaccines. Ask yourself how well it's working. How well has it worked out for you? You got your vaccines. You still couldn't travel. You still can't travel. You can go to the workplace. Now some of us are starting to be excluded from these areas, but that makes it even more obvious because now there's no unvaccinated people around you, and you still are doing the exact same things.
For Rebel News, I'm Tamara Ugolini, and the guest that I'm bringing you today came under fire after he proclaimed on talk radio that the spike protein in the mRNA COVID-19 injections is a toxin and has potential to cause serious damage.
We thought the spike protein was a great target antigen. We never knew the spike protein itself was a toxin and was a pathogenic protein. So by vaccinating people, we are inadvertently inoculating them with a toxin. In some people, this gets into circulation, and when that happens in some people, it can cause damage, especially to the cardiovascular system. And I have many other, I don't have time, but many other legitimate questions about the long-term safety, therefore, of this vaccine. Right. For example, with it accumulating in the ovaries, one of my questions is, will we be rendering young people infertile, some of them infertile? So I'll stop there. Okay. I know it's heavy hitting, but
I'm up against the clock. I need like an hour when I talk to you because you have so much information, and of course you're one opinion of many. But you know it's interesting because you have a different look at it.
Viral immunologist Bryam Bridle has since spoke alongside Derek Sloan in Parliament, a broadcast relayed to the Canadian public through CPAC, that is the Cable Public Affairs Channel. It was the most viewed video on the CPAC's YouTube channel before it was removed without warning. Before we get into my interview with Dr. Bridle, here is a clip from the CPAC's website directly.
I've got a couple of colleagues locally at my institution who have stood shoulder to shoulder with me. I'm part of the Canadian COVID Care Alliance. This is a group of individuals. In fact, the reason that we exist is sad. We exist because we're like-minded in the sense that we all want to be able to speak openly and freely about the science and medicine underpinning COVID-19. And we don't feel safe to do it anywhere else other than within our own private group, where we feel safe. Myself and one other member of that group, our group is growing to 100 members and is still rapidly growing. We're quite new. And only 2 of us are willing to talk to the media about this group. The others are too afraid for their jobs. They're afraid. They're physicians that are afraid they're going to lose their license to practice. And they're academics and other professionals who are afraid that they are going to lose their jobs. The scientific literature has exploded over the last 16 months, and we understand so much more. Okay, and so now we're looking at vaccinating children, and it's no longer okay to proceed based on assumptions. And so what we have found is that this assumption about the vaccine remaining in the shoulder does not apply to this novel vaccine technology. It's never been in people before. These messenger RNA vaccines get distributed throughout the whole body. What we have found, in fact, is that as little as 25% of the dose remains in the shoulder, and it traffics all over the body. Also, many of you might have heard of polyethylene glycol, because that is one of the components of the vaccine that sometimes people develop an anaphylactic shock to. Okay? The polyethylene glycol was put in this formulation. A lot of people don't realize these lipid nanoparticles, these little bubbles of fat that carry this little blueprint that helps our cells make the spike protein, those lipid nanoparticles were actually originally designed to disperse throughout the body. They were designed to be gene therapy vectors and also carry drug cargo, especially into the brain, where it could be used to treat things like Parkinson's disease and Alzheimer's disease and brain cancers. That polyethylene glycol, just so that you know, is designed to help facilitate that spread throughout the body. You get about 5-fold greater spread throughout the body with the polyethylene glycol there. Do you know why? Because when the polyethylene glycol is there, it actually helps the lipid nanoparticles bypass the very cells of our immune system that are supposed to pick up the antigen and take it to our lymph nodes. So arguably, by having that polyethylene glycol there, not only are we promoting spread throughout the body, but we may actually be dampening the very functionality of the vaccine that we want.
First and foremost, can you tell us some of your background and the research that you've been undertaking at the University of Guelph that makes you qualified to speak on this topic? And then subsequently, what the current landscape looks like for you in terms of being on campus and continuing your research?
Sure. Yeah, thanks for having me tomorrow. I appreciate it, and appreciate having the opportunity to share some of my expertise with your audience. So I am a viral immunologist at the University of Guelph. My title there is associate professor. So I manage a research team, and my research program has focused, focuses entirely on the development of new immunotherapies. So what that means is utilizing the immune system as a tool to tackle disease. And I focused on two areas. One is infectious diseases, and so that's of course relevant to COVID-19 in the sense that that is an infectious disease caused by a virus, and the name of that virus is SARS coronavirus 2. The other thing that I developed new therapies for are cancers, treatment of cancers. And in both cases, the form of therapy that we're working on are vaccines. And so what happened is at the beginning of the declared COVID-19 pandemic, what I was able to do, my research team were able to pivot very quickly along with key collaborators at my institution and convert our cancer vaccine platforms over to COVID-19 vaccine platforms. And so I also teach the value of, I teach immunology to students at the University of Guelph, both at the undergraduate and graduate level. And included with that is teaching about vaccinology. So that people understand, vaccinology, it's a subdiscipline of immunology. And so immunologists have very deep expertise in the area of vaccines and how they're developed and how they're to be used. And so not only is my research program focused entirely on the development of vaccines, but my entire publication history is focused on disseminating information to the public about and the scientific community about vaccines. So I teach my students the value of vaccines. I am a vaccine lover. So although I love vaccines, I have some serious concerns about the current ones for various reasons. And I over the course of the declared pandemic, I've had probably about now 250 media engagements. And over time, this has led to some people, especially colleagues, really attacking me. So I'll admit that trying to, as a public servant, and I always emphasize in that the servant part, my job is, since I work for an institution that's funded by taxpayers and my salary is paid for by taxpayers, it is my duty as a public servant to answer questions that members of the public like yourself ask, and I answer them based on the science that I understand, and I answer them honestly. And in this day and age, unfortunately, that seems to get many of us in trouble.
Yeah, that's very unfortunate that any dissenting voices, we can't engage in that scientific debate anymore in wake of this COVID-19 pandemic. Now, I know that you've been working on this SARS-CoV-2 vaccination. Biography on the University of Guelph website notes actually that the long-term goal is to develop a flexible technological platform to rapidly develop vaccines against pathogenic coronaviruses that may emerge in the future. How does that mandate conflict with or support what you're saying about the current COVID vaccine rollout program?
Well, okay, so first of all, one of the things that I'd like to mention is I have received funding. So because we are actively pursuing research and developing COVID-19 vaccines, I've received funding from both the Ontario government and the federal government to pursue this research. And interestingly, the technology that we're working on is also a new technology. In fact, many people have probably heard about, in Canada, we had, I guess now the infamous AstraZeneca vaccine fiasco, where we rolled out that vaccine, and then we ultimately had to halt that vaccination program because it was deemed to be too dangerous for adult Canadians due to the risk of potentially severe blood clots. So that vaccine is based on what we call a virus vector. So it's a virus that carries the genetic code for the spike protein, which has been deemed to be a great target for protecting us against the SARS coronavirus 2. And this virus that carries the genetic blueprint for the spike protein is called an adenovirus. So it's a weakened cold-causing virus, essentially. And actually, our vaccine platform, one of our vaccine platforms, is also using an adenovirus. So the exact same technology, or at least very similar technology. Plus, we have some other what we call virus vectored vaccine platforms. So our technology actually is very similar to the technologies that I have some concerns about, and I have some concerns about the nature of the spike protein that we're using, because what we've learned is it's not. Ideally, with the vaccine, what you want to target is you want to show the immune system something on the virus that it can target, and the ideal thing is that what you're targeting is what we call an inert protein, meaning it doesn't do anything to our body. It simply serves as a target so that our immune system can recognize the pathogen we're trying to fight off. And in this case, we've discovered, well, others have discovered, that the spike protein is not an inert protein. In fact, it is bioactive. And what that means is it's doing things. It can do things in our body and do things that cause harm. So in fact, with my own research program, I have a PhD candidate who is actively working on this. And so because of my concerns, we've actually had to go right back to the starting line, right? And so one of the ideas we have is we're working on seeing if we can redesign the spike protein to still have it serve as a useful target for the immune system, but remove all these biologically active components that the protein has, such that it can no longer cause any harm in our body. So that's what we've been doing. As a result of expressing these concerns, what I can tell you in my workplace, it's been awful. It has become a very poisoned work environment for me. I have many colleagues who have been harassing me incessantly. There was relatively recently, a letter signed by 83 faculty members at my university that was released publicly, telling the public that I'm lying to them. It did not contain any scientific information. Their, quote, scientific references was pointing to fact checker sites. And what they don't seem to realize is I've already rebutted all of those fact checks in other public interviews. But of course, that's not available to anybody. But rather than discussing the science with me, or presenting their own science that shows that the science that I'm presenting is wrong, it's always Bryam is lying to the public because these people over here said so, because that fact checker said so, because that fact checker said so. I always respond with the science. And this has been ongoing. I have colleagues who have been unbelievably immature in the realm of social media. I do not have a real social media presence. I do have a false Twitter account that was developed to impersonate me. I have a website that used my domain name to impersonate me, and this harassment. I mean, my colleagues, they've resorted to name calling. I saw, and of course the public and students in our own institution are very upset, and they're very upset with my institution that they're allowing this very immature. It's like elementary school type behavior to occur online. The name calling. I was recently sent a tweet where my colleagues were accusing me of killing pregnant women and babies because of my messaging. I mean, these are very serious accusations. So I really feel like I'm in a poison environment right now in my workplace. And in fact, I am, because of the current vaccine mandate that our university has adopted, I am currently banned from the campus for at least the next year. I have a student who just started last week. I haven't been able to meet them in person yet, and won't be able. And they're going to be there for the next 8 months. And like I said, I'm banned from the campus for the next year. So this is a student who is starting in my laboratory. I won't even be able to meet them in person for the duration of their training in my laboratory. I have to figure out how to teach exclusively from remotely, and I have one of the most active research programs on my campus. And I have to figure out how to do all of this remotely now. And the other thing that's happening on my campus is I'm trying to put out fires left, right, and center. We have staff members who are being physically escorted off our campus and sent home and with their work terminated while they're being put officially on leave without any pay. They're trying to figure out how to sustain their families. We have had students and their parents physically escorted off of our campus, physically removed from their residence on campus and sent home with their programs being terminated. We have students who have deferred a year because they're trying to stay out of all of this hassle. My workplace at the moment is in chaos, and it is a very poisoned environment for those of us who do not want to have COVID-19 vaccines forced upon us. And we have very legitimate scientific reasons for not wanting this. Could I give you one great example, Tamara? And I can use myself as an example of how I feel that these, one of the reasons why I feel these vaccine mandates are egregious. So I do not have to share with anybody my personal and confidential medical information, okay? However, I'm going to in this situation because I think it's an important example of why we really have to think carefully about forcing these vaccines on everybody. So I have participated in a clinical trial that was designed to evaluate and develop a very comprehensive test to look at immune responses against SARS coronavirus 2. And in particular, I participated in a control group, which is an unvaccinated group. The whole purpose of this group actually is to look at, okay, so first of all, initially it was assumed when the study started a year and a half ago, and so it was assumed, remember we were all told that we were naive, that we had never seen this virus before. So initially we were expecting, so nobody would have evidence of immunity against this virus. Now, this is interesting. It turns out that a lot of people have immunity. So first of all, there's two types of immunity that people have in the absence of having been vaccinated. We're finding that there's a lot of people who seem to have what we call cross-reactive or cross-protective immunity, which means they've been exposed to other coronaviruses, not the SARS coronavirus 2, but there's enough similarity between some of those proteins and the proteins that the SARS coronavirus 2 has, because it's not a completely different coronavirus, right? And so so people have antibodies that they've developed against these other coronaviruses that recognize the SARS coronavirus 2. The other alternative is there is naturally acquired immunity, meaning if an individual gets infected with SARS coronavirus 2 and clears it, guess what? This seems to be the big news these days. Our immune systems work. They actually do what they're designed to do. We mount immune responses. And now the scientific literature is very clear on this. Those natural immune responses are robust. They target multiple components of the virus, not just one single protein. So therefore, this is an immune response that's very hard for novel variants to circumvent because they would have to change so many of their components to circumvent it. So it's likely more protective against emerging variants. The other thing that we now know, and this is just cutting edge, very recent, right? There is widespread public acknowledgement of the fact that these vaccines, that they have what we call a duration of immunity. That's an immunological term. And what it means for your audience is, it means how long are you protected after being vaccinated? So the length of time that a person is protected after receiving these COVID-19 vaccines seems to be horrific. 4.5, maybe up to 6 months, but probably it looks like it's more in the ballpark about 4.5 months. This is exactly why in the United States, they are aggressively rolling out the third dose of the vaccine right now. It is why in Israel, they are already well on their way to giving everybody their third dose. And it's why in Canada, we have followed suit and we have started vaccinating the frail elderly and long-term care facilities with the third dose. I will tell you tomorrow, as somebody who develops vaccines, it is very difficult to make a vaccine that would perform this poorly. You think about it, our childhood vaccine regimens, I mean, in most cases, we receive those vaccines and never require a booster for the rest of our lives, right? This is an incredibly poor performing vaccine. So and what I'm saying is, therefore, when it comes to every aspect, the robustness of the response, the breadth of the response, and the duration of the response, natural immunity beats the vaccine-induced immunity on all counts. So what this means essentially, if somebody has naturally acquired immunity, they do not need to be vaccinated. They are already at least as protected, and I would argue better protected than somebody who had their immunity conferred by the vaccine only. Now, this is important. So again, I don't have to reveal this, but I'm happy to as an example. So I've been tested and I have robust, broadly reactive immunity against SARS coronavirus 2. And one of the proteins is not very similar. One of the proteins in SARS coronavirus 2 is not very similar to that in other coronaviruses. I have a very robust response to that. So what that suggests is that I have been infected with the SARS coronavirus 2. So early on in the pandemic, I got I would say a moderate respiratory infection. It took me a month to get over it. I was tested at that time. It was ruled out as COVID. There was no evidence that I was infected with SARS coronavirus 2. So that means that I was infected with SARS coronavirus 2 at some other point in time and wasn't even aware of it. And this is the case, especially for children. There's many cases of people getting infected, and those people, this is not even a pathogen. So they either get very mild symptoms or none at all. They don't even get sick. But we generate this immune response. So in other words, I have naturally acquired immunity against SARS coronavirus 2. Now, there is all kinds of emerging data that demonstrates. So, for example, there's 3 preprint articles right now that are posted online, all from three independent research groups. And what it shows is that if you have naturally acquired immunity to the virus, meaning if you have previously been infected and got rid of that virus from your body, these vaccines are more dangerous to those individuals. Side effects are more severe. And this fits with my understanding of how these work. Because again, the biology, these vaccines don't seem to stay localized in the shoulder. They seem to get distributed throughout the body. And what that means is, if these lipid nanoparticles, right, these little fat bubbles that are in these messenger RNA vaccines, that's the Pfizer and Moderna vaccines, if they get distributed throughout the body, if you think about it, if we have pre-existing immunity, so right now I have antibodies against the spike protein. These lipid nanoparticles, there's nothing in the vaccine formulation that contains the spike protein, nothing. So if that were to be injected into my body, my antibodies can recognize nothing on those little fat bubbles. But what happens if those fat bubbles, as they get distributed through my body, the way they're designed to work is they put that little genetic blueprint that they're carrying into our cells. And then they get our own cells to produce the spike protein. And the spike protein gets stuck to the surface of our cells. So the first time my antibodies would see the spike protein is when they're appearing on the surface of my own cells. And so my antibodies would start causing me to kill off my own cells. So again, this is theoretical. All right, I'll point that out. This is theoretical, but this is the logical mechanism that would explain why people who have pre-existing immunity would be susceptible to more severe adverse events, side effects after receiving a vaccine. So this is the thing. So this is a demographic, and there's many of us who have naturally acquired immunity. This is a demographic, there is no question, for which there should be no vaccine mandate whatsoever. The reason is there's zero net benefit to receiving the vaccine because we're already better protected than those who have had their immunity conferred by the vaccine only, right? So there's no benefit to us or anybody around us to vaccinating us, but we are at enhanced risk of the potential harmful effects of the vaccine. And I have pushed since the beginning of this pandemic, we need to be monitoring the status of immunity in all of us in Canada. We had the opportunity to do this, and we are not doing this. Remember, the purpose of vaccinating is not to simply stick a steel needle into the shoulders of people. The goal in Canada has to be to try and get as many people immune. A vaccine is one tool to achieve that. The other way, if you're naturally immune, you're immune as well. You're protected. And so we should, and since there's greater dangers to those individuals, we should not be injecting them. Instead, what we should be doing is offering these tests for people so that they can make the most informed choices for themselves in terms of the health. And if somebody has naturally acquired immunity, they should not be vaccinated because, again, there's zero net benefit, and greater risk associated with it. And it's all about risk-benefit analysis.
Absolutely. And what does this test look like that you have received to determine that you have these antibodies present?
Yeah, this test, so it's a very comprehensive test. So there is one that's commercially available through Life Labs in Canada. It's it's a test with low sensitivity. A lot of the antibodies against the spike protein tend to wane quite quickly over time, which led to a huge misconception early on in terms of non-immunologists interpreting that, because they viewed it as, since the spike proteins were disappearing fairly quickly, that naturally acquired immunity therefore must be very short-lived, right? And therefore it's no good, and that's why we would need to be vaccinated. One of the reasons. Well, It's not the antibodies. Those are proteins in our body, and over time, proteins will get cleared from our body. It's all about what we call memory B cells. So if you have immunity conferred, we have memory B cells. It's those B cells that produce the antibodies. The antibody can disappear over time, but as long as you have those memory B cells, as soon as you see the SARS coronavirus 2, those B cells will immediately start pumping out massive quantities of the antibody again, and you're protected. So that's the one commercially available antibody test that I'm aware of, Life Labs. So it's not very sensitive. It only looks for spike protein specific antibodies, and many of those again can wane fairly quickly. So this test instead looks at, I think it looks at the response to 12 proteins from the virus, including the spike protein. And many of these antibodies, especially against the other components, are very long lasting. So this trial has been running now for 1.5 years, and people have been retested. And there's evidence that those who were naturally exposed to the virus or even had cross-reactive immunity, right, that were identified early on at the beginning of the trial, still have evidence. So this is able to detect these antibodies against multiple components of the SARS coronavirus 2 up to at least 1.5 years. And some people, most people it appears, after they developed these antibody responses. So it's very robust. And so the nice thing is it can differentiate between those who have had immunity conferred by the vaccine only, because they'll only have antibodies against the spike protein. And then obviously if there's any antibodies against the other components, since those other components aren't in the vaccine formulations, that is a clear indicator that somebody has natural immunity.
Which again, you've stated is superior to just that one specific antibody versus the naturally acquired broad spectrum, if you will, immunity. Now, I just want to get back to some of your concerns, because you had sent me a letter that you forwarded to the Thomas Valley District School Board regarding their mandatory vaccine policy. And in there, you note, like you've already said, issues with the spike protein and how it can theoretically interact with the body in a way that damage the cardiovascular system, namely the heart, and potentially cause neurological damage. I mean, we have seen a lot of people get vaccinated now and some documented reactions. So is there any pattern of reactions or clinical evidence that supports your theory about the spike protein?
It's broadly accepted now that heart inflammation is linked to these vaccines to the point where all four countries in the United Kingdom will not vaccinate their children on this basis, right? They have rescinded their vaccination program for healthy children on this basis. It is broadly recognized, even in Canada now. Ontario's recent data, Public Health has now admitted, right, that they just recently put out a report of well over 100 people who have had to be admitted to the hospital with heart inflammation following this vaccination. People may not realize in Canada, we have even added to the label for these vaccines that heart inflammation might be linked to them, right? So yes, everything that I have cited in terms of potential mechanisms, the reality is at the end of the day, what the mechanisms still remain largely theoretical because people are refusing to run the proper studies to address these questions. But this issue that I raised of the distribution of the vaccine, that it's not staying in the shoulder, et cetera, that all would explain these serious side effects that we are seeing. And I will guarantee for you tomorrow, now I have no numbers to show this, right? This is the problem these days, but I will guarantee that the side effects of these vaccines are being dramatically underreported. To what degree exactly, I cannot tell you. But I could go over all the reasons why that is occurring. But the point is, we are dramatically underestimating them. So even when there's an admission of a problem occurring, the numbers that are coming out, I can guarantee, are a dramatic underestimate of the true numbers. Okay, and we are also overestimating the problem. It's a different issue altogether, but because of the nature of how we're running these tests and defining cases. And so this is the problem, where we're over-exaggerating the problem and propagating excessive fear, and we're underestimating the problem associated with the vaccines, right? And garnering overconfidence in their safety. So yes, this explains it with the heart inflammation. And this is important. So my concerns get amplified, especially in the context of children, because the dangers of COVID-19 to young people is so low. that we have to make sure that we set the standard for safety of these vaccines extremely high. Now, this is very important. This is cutting edge science as well. So I'm excited because you're the first person to have interviewed me since a lot of this really important science has just come out. So a study has just come out of California and the United States showing that in young people, young males, so males 12 to 15 years of age, this is an important age group, right? Because these are the children or adolescents we're currently vaccinating in Canada. So males 12 to 15, it's been shown they have a six-fold higher chance of developing heart issues with the vaccine than they do from COVID-19. Right? That tells me all there is.
How do you know, though?
The heart issues aren't the only issue with that.
Right.
Well,
How do you know that it's the spike protein if we don't know all of the ingredients in for instance, specifically the Pfizer vaccine? How do you know it's the spike protein and not something else?
That's a great point. As a scientist, this is what I've been pointing out, right? Since I'm not the one who's actively working with these, and nobody will allow me to work with these specific vaccines and run the studies, we have to depend on the companies. Really, the companies, the onus is on them to evaluate the safety. So we've been raising all these questions, and these could readily be addressed in studies, properly conducted experiments. So I totally agree with you. I've raised concerns about the spike protein because we have clear-cut scientific data that suggests the spike protein, there's two issues with it. If it were to get freely into circulation, it can cause potential damage if it's at a high enough concentration. Now, I was criticized for citing the one study that showed that the spike protein can get into circulation only involved 13 people. I was fact-checked to the gazoo on that, with people saying, Dr. Bryde doesn't know what he's talking about. And those 13 people, 11 of them had evidence of the spike protein circulating, but it was at extremely low concentrations. Concentration so low that it should not be dangerous. They've missed the point. In Canada, why did we shut down the AstraZeneca program? Because 1 in 55,000 Canadians were at risk of potentially fatal blood clots. I'll reiterate that, 1 in 55,000. Not 1 in 11, which is how many people had the circulating spike protein in the study of only 13 people. So if, and this is a big if the mechanism of damage that was causing things like the blood clots were the spike protein getting freely into circulation, guess how many people I would expect to see high concentrations in? About 1 in 55,000 people, right? So to fact check me on that is crazy, because if all 11 of those people had high concentrations, it would mean that my hypothesis is absolutely wrong, because if everybody had high concentrations, everybody should be suffering these problems, right? So that's one issue with the spike protein. The second one that we definitely know about is if you express it on the surface of our own cells, which is what. So that's the thing. Even if people are arguing, Dr. Bridle has been completely wrong, there's not very much that gets distributed elsewhere in the body. That's definitely not the case. They keep forgetting that if you look at the injection site, they could only find 25% of the dose left at the injection site after 48 hours. But even if let's say it all stayed there, it's getting our own skeletal muscles then to express the spike protein. And so as soon as you show the spike protein and you start later on developing antibodies against it, you're causing an autoimmune response, right? So that's why I spoke about the spike protein. But I hear you, Tamara. There could be other things in there. Now, so for example, we know that the lipid nanoparticles themselves, forget about the spike protein. If you take that messenger RNA out, these lipid nanoparticles, when they fuse with our cells on their own, they're what we're calling highly reactogenic. Basically, what that means, kind of in layman's terms, is they cause a lot of local inflammation. That's why a lot of people, after they get the injection, their shoulders can get very sore, to the point where some people can't even lift their arm for a couple of days, right? So it causes inflammation. That alone could be causing harm. So for example, if these lipid nanoparticles were to go to places like, say, the ovaries, and then cause inflammation, those are tissues. We call them immunoprivileged sites, because these are sites where there's very fragile tissues or cells present that you can't afford any damage. And guess what? Inflammation causes a lot of bystander damage. So damage to cells in the surrounding area. So you don't want that happening in your brain, where you have you don't want to cause any non-specific damage to your neural tissue. You don't want that in your eyes, right? But also other immunoproliferative sites include the testes and the ovaries, because you don't want to destroy the gametes, right? The eggs there.
Right.
So there's an example where, yes, you could have something that has nothing to do with spike protein just by seeding that tissue with a reactogenic set of lipid nanoparticles and cause inflammation, you cause damage. So I agree. And so there are other components of the vaccine that could also be causing damage. The only way to really rule these ideas in or out, and I'd like to see them ruled out before we are forcing vaccines on everybody, is to conduct the proper studies.
And on that note, just in closing, Dr. Bridle, for these people who are being mandated and coerced into this injection, what's your message for them, or maybe even more broadly, a message for these public health policymakers as we move forward and see this being heavily mandated for students, faculty, workplaces, everyone?
Yeah. So again, so people have to be aware of the science. This is the thing. We have to. I see too many people making decisions because other people told them simply to make those decisions. People have to, for themselves, they have to really look at the data that's out there, ask themselves, what is the credibility of the person telling me this, right? Do they have anything on the line, anything to gain, anything to lose? Really, and evaluate, where are you getting consistent messaging? This is the important thing tomorrow. Right now, we're a polarized society. We have really, individuals are really polarized on every issue to do with COVID-19. Now, this is the thing. What I recommend to people is when they're evaluating the source of information, I have noticed, I don't know if you've noticed this, but we've created in Canada a relative minority, and that would be the people who are providing messaging that does not fit within the very narrow public health messaging that's going out right now. And then you have a majority that are adhering to this, and that's all they will talk about, and they don't want to hear anything other than that, right? This is dealing with the censorship. So this other more smaller minority group is being censored. And when you look back on history, when you have a majority group in which massive fears are being instilled in them of the minority group, this is a dangerous situation. This is not how we should be functioning. And what I'm finding is that the group, this majority group, when you look at the nature of their messaging, the fact that they will not allow any open dialogue and they won't engage in dialogue. I have one person after all this time tomorrow, not one single physician or scientist has ever taken up my offer to speak with me publicly, to have an open discussion about the science in front of the public. That tells you something. So they will not communicate with us. They call us names. They attack us. They tell everybody that we are, evil, that we're going to lead to the death of people. And then I find that the people on this side tend to be, on average, I'm seeing messaging that's more even-handed. There's not the name calling in return, right? There's greater maturity. And I think people have to start looking at this and asking themselves, right? So that's one aspect. Become informed. Be open to deep critical thinking about these issues. And then the other thing tomorrow, there are people have to. So when they do that, they will see there are genuine concerns about safety. I just cited a six-fold higher increase of heart inflammation in young males than COVID-19 itself. We can't keep using our children as shields in what I call this adult battle. And the other thing is, people have to wake up. So the simplest thing I would say is, look around you. So as I mentioned, I can't go to my campus, even though I have rigorous, robust natural immunity. I'm not allowed on, and it's all supposed to be about immunity. But fact is, and I just want to say one thing actually that I forgot to, because there's also non-responders. This is the interesting thing. If you look at the extreme, there's somebody like myself who doesn't have a vaccine passport, but I'm very well protected against COVID-19. And then there could be a person beside me who has a vaccine passport, so they can go on my campus. And the reality is, anytime you apply any medical treatment, there's always a small group that we call the non-responders. And we've seen this in this clinical trial. So the people get the vaccines injected and they have no response. So they're carrying around a card and they're not protected at all. I can demonstrate through scientific data that I'm protected, and yet I can't access my campus or these other places. It's crazy. And so so my campus right now is a 100% vaccinated zone. Guess what? The goal that our public health officials have right now is to make our world a 100% vaccinated zone. So people have to start asking themselves, look around you. When you enter these 100% vaccinated zones, what does your life look like right now? On my campus, guess what? Everybody's vaccinated and everybody's been told that these vaccines are highly protective. But guess what? everybody on my campus, right as we speak, as school's active right now, they're all wearing masks. They all have to physically distance. They have spots on the ground where they have to stand in line. They get told what doors to enter, which ones to exit, when they can enter, when they can exit. They've had limitations on how long they can eat their food at lunchtime unmasked, and then they have to put the mask back on. We have a 3-stage policing system for anybody who contravenes any COVID-19 policy on our campus, with the final one being having the police called and the person potentially being escorted off campus. So what has this bought you? So if you really believe this, if you believe the messaging about the vaccines, and you believe even the messaging about those of us who have serious, legitimate concerns about the vaccines, that we're all going to be a danger to you, right? For example, our children are the super spreaders of the virus, then fine. You walk off of campus or you walk out of your workplace where everybody's vaccinated, and fine, put on your mask and physically distance if that's what you think. But why then on campus are you doing exactly the same things? Why is nobody on campus now allowed to take their mask off? Why are they not allowed to shake hands? They're 100% vaccinated. That tells you a lot tomorrow. That tells you all people need to know. You look at Israel right now, they are rolling out the 3rd dose. Why? Because more than 80% of their population has been vaccinated. And the Delta variant is running wild in Israel. And they're going through this 3rd dose, right? So that tells you that everybody said, we probably herd immunity, we probably have to reach 60%. Higher would be better. And then it was 80%. Guess what? For Ontario, for us to go to our step 3, which we paused with, it was at 80%. Israel's is at over 80%. They have exceeded our highest goals that we set in Ontario, for example. And the Delta variant is running wild, and they're looking at having to administer a 4th dose. So I also want to tell your listeners, I see this has been my nightmare, but I see this potentially all unfolding in the same way and starting to encompass influenza virus. Okay, I think that we are setting up our society so that we're going to start, no longer will annual flu vaccines be optional, but we're going to apply the same technology to the flu. And if we can do that, because if we highlight cases of the flu, like we do the SARS coronavirus 2, and we don't differentiate mild from moderate to severe, it's going to scare everybody as well. I've told everybody that. And historically, if we ever put the spotlight like we do now on the SARS coronavirus 2, on the influenza virus, it would seem scary as well. So people have to wake up. These vaccines are poor quality. They are very poor quality, such that I would define them as garbage. I literally teach my students what good high quality and low quality vaccine looks like. Look around you. These honestly are garbage vaccines. Ask yourself how well it's working. How well has it worked out for you? You got your vaccines. You still couldn't travel. You still can't travel. You can go to the workplace. Now some of us are starting to be excluded from these areas, but that makes it even more obvious because now there's no unvaccinated people around you, and you still are doing the exact same things.
Bryam Bridle is one of many scientists trying to engage in scientific debate to address the COVID-19 pandemic response in a balanced way, while using previously well-established criteria to adequately weigh the risk versus benefit of many public health decisions. If hospitals and general doctors can no longer do this in wake of COVID hysteria, how exactly can we trust them with our health? In the name of hygiene fascism and medical cartel mandates, we seem to have forgotten actual scientific debate. For Rebel News, I'm Tamara Ugolini. We have started a litigation campaign to push back on vaccine passports being ruled out indiscriminately across most of Canada. To support this massive legal undertaking, please consider donating what you're able to at fightvaccinepassports.com. Fill out the form there and tell us your story, or simply get in touch to stay up to date on the litigation proceedings. That's fightvaccinepassports.com.